Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening and welcome to Pause for the Truth. I am Jocelyn Turner, your co host. It's a beautiful day in Northeast Florida. I don't know where you are, but it's a beautiful day in Northeast Florida. But thank you for joining us this evening. We're having a great discussion, great topic, something that so many people need, something that people struggle with. But we have two local experts who are going to impart their wisdom and knowledge on us this evening. Of course, I cannot do the show alone. Joining me as co-host is Dr. Rogers Kane. How are you doing, Dr. Kane?
I'm good. I'm still just hopping to the beat for our intro.
I know, right?
and then sometimes I remember when I first started watching our intro, I'm going like, hey, how they gonna start without me? And then I realized those are recorded shows, previously recorded ones. So anyway, I'm doing just great. I want to welcome our guests. Not only are they my colleagues, but I consider them good friends. That are much smarter than I am, and that's why I have them on the program tonight.
And they are here, Dr. Kane. I am just meeting Dr. Price. We've had Dr. Green on before, but they are here to talk about heart disease and hypertension.
Yep.
Now, if anybody's watching this show, somebody knows somebody, Doctors Price and Green, who has high blood pressure, right?
Right.
And I, for the life of me, don't understand why hypertension seems to be so prevalent in the African American community, especially. Can you explain that to me? Why that is, one of you?
Well, some people actually trace it back to when we came over from Africa. You know, those who have survived because they had that gene that helped them with salt to retain salt. So they made it through the Middle Passage. And I guess genetics has just played a role down so that, you know, people have more problems with high blood pressure, especially with salt, which we tend to like a lot of.
So now I know why I have an affection for salt, because it's in my genes. Thank you, Dr. Price. So it lets me know that.
No excuses.
Okay, I tried. So, you know, and there's a question is, do you know anyone who doesn't have hypertension? And I actually do know someone who does not have hypertension, no matter how rampant it is. I remember when, unfortunately, Dr. Price, I cannot raise my hand. I was actually diagnosed when my dad got a cancer diagnosis. It was very stressful for me when he was given an end of year notification sentence. It was very traumatic for me, and that was when I was diagnosed. But fortunately, after a few years, I began to manage it properly, and I think people don't know that you can manage it. It doesn't have to go out of control, but it seems to go out of control so much in our communities. I was sharing with Doctors Green and Price prior to starting the show that, having tracked data for the past several years, it's amazing how heart disease is either number one or number two in the leading causes of death in this country, state, county, you name it. It flip-flops. It's amazing to me. Like, why is it that why does it stay? Why does it remain as a leading cause of death? A lot of it, I know, is tied to lifestyle choices, the habits that we have, the bad habits that we have. Dr. Price mentioned salt, but the other things. Dr. Green, what are you finding? Are the cases of heart disease and primarily what you're seeing related to folks' lifestyle choices, or is it a lot of hereditary, or both?
Well, well, thanks for having me on, by the way. Good evening. Always a pleasure to be here to share with the regular community. I see this as a very important service that we can provide. So when Dr. Kane called me, the answer was, when do you need me? So
Thank you.
and we see this as something that we should often do. The and the answer is both. It's both genetic and it's both lifestyle, and they're very challenging. The genetics, of course, we picked up from our parents. I tell my patients the only way you can change your ability or your affinity or your destiny with respect to hypertension is to choose your parents. So that's a little difficult to do. And I also tell them that if you're African American, you're almost certain by the time you get past 40, 50, in around that time to begin to see that your blood pressure will start to rise. The problem, of course, is silent. So unless you pay attention to it, it is a silent thing. Some people know because they can get headaches, but you can't wait for it to get that soon. Other people know or become aware of it because their parents are hypertensive, so they have a hunch along the way that they will become have high blood pressure as well. But for the most part, the once you have that background that you can't change, which is genes, now the thing that you can change is lifestyle. So both of them, genes and lifestyle, are directly related and directly causative in having a high blood pressure.
Let me back up a moment and forgive me, both of you. Would both of you please share with our audience a little bit about you and your specialty? Because I failed to say that in the beginning of the show, and of course, I'm going to punt it to Dr. Price first.
Okay. Well, I'm a nephrologist, which is a kidney doctor. I do see patients who have really difficult to control high blood pressure as well. And I guess my main goal is to try to keep people off of dialysis, but they eventually, some of them do go on, and I take care of them then. We try to get them kidney transplants, and we see them after the transplant to hopefully maintain that transplant.
Thank you. Dr. Green?
Well, I'm a heart specialist. First and foremost, I'm an internal medicine specialist who happen to like cardiology, so I'm a cardiologist as well. And the the only reason I'm told by one of our guests tonight is that the only reason the heart exists is to pump blood to the kidneys. So unfortunately, that's an inside joke, by the way. But the heart is of course very important, and nephrologists like Dr. Price and cardiologists like myself with Dr. Kane in the middle, we fight over what we are going to do to treat patients because sometimes we tend to pull in opposite directions when we come to look at the heart and look at the kidneys and the drugs that we use. And then Dr. Kane, the primary care physician, gets caught in the middle, and sometimes he has to be a referee. But it all works out because we're all trained for the same goal, to not have the blood pressure affect the heart and at the same time not have it affect the kidneys. And both of those two things can lead to very bad outcomes. The kidneys can, as Dr. Price mentioned, all the way to dialysis, which no one of us wants. And of course, if you don't pay attention to the high blood pressure, it is like going to the gym every day and bench pressing the heart. The heart will get thick and tough and not relax and work properly, and you run into trouble. So we both have our roles to play when hypertension, high blood pressure comes into the mix.
Yeah,
So,
let me say something. Um, they may get mad at me for saying it. I get in between a husband and wife scrap battle. For those that don't know, Dr. Price and Dr. Green are married. So if she says one thing and he says another, and that's what I get in the middle of. A husband and wife scrap, but they usually concur with each other because they're both after the same goal. And they're my favorite cardiologist, my favorite nephrologist. Oops, I hope Dr. Dole ain't listening, but
Dr. Price, it seems to me that more and more dialysis centers are cropping up around town. I mean, when you see a new business and you look, I'm almost disheartened when I see, oh no, not another dialysis center, because it is a strong indication that that means that we're having more and more people, it seems, I don't know, obviously, that are getting into end stage renal disease. And are you finding that more and more? And are they younger? Are you seeing any of the demographic changing at all?
Yes, there are more people going on dialysis. It used to be that, the most common cause of death in people with chronic kidney disease is the heart, and a second is infection. So it appears as though with therapy, having a heart attack, people are now surviving it, so that we are now seeing more people, get to the need for dialysis. And you probably have noticed that a lot of the dialysis units are now popping up in African American communities, because, diabetes is still the most common cause of kidney failure, and high blood pressure is a close second. But in African American community, it's actually high blood pressure being the most common cause of kidney failure.
And
And
people,
we have both. Be I quite frank with you, it is. I mean, it's so both permeates our community much so. And I'm wondering, and Dr. Price, you can correct me if I'm mistaken. I do feel like a lot of part of the reason for us seeing more of the dialysis unit is because we're making more diagnoses and because we have more African American physicians, great physicians out there searching, looking, finding the kidney failure, and with especially African American physicians, because we're looking harder, and without sounding racist, we do tend to be more concerned, and we tend to be more sensitive to our community.
Yes, that's true. That's true. And Ms. Turner, what you said about being younger, we do find that in African Americans, they do develop kidney disease at a much younger age, and high blood pressure as well, and diabetes. And some of that is lifestyle. So I can't all blame it on genes, but lifestyle.
yeah, when I was diagnosed, I remember having a conversation. I was working at the health department at the time, and my background, since I'm amongst physicians, is I'm just a health educator, right?
Don't say
And
just, don't say
and
just.
yeah, and I remember I asked my colleagues who are registered dietitians, what can I do in order to control my blood pressure? Will I ever get off this medicine? Because that was my goal. And the first thing that I was told by one of my former colleagues, no one hardly ever gets off of blood pressure medicine. That was so disheartening to me. And and the person said it's possible, but it's not easy, right? Not like some other things like diabetes, for example. Unfortunately, and I've been very open with it. I have both, actually. And fortunately, intellect did kick in, and in the 4 years that I was diagnosed with diabetes, I've never had to take medication because I've learned how to manage it. So basically, I know what I've been doing wrong, right? It's not easy, but I tell people it's harder to me to remember what medications to take every day. I never want to do that. I never like the idea of pricking my finger because I don't like pain, right? So that part is harder. We had a registered dietitian, Linda Brown, on with us a few weeks ago, and we were talking. I was asking her about reading labels. Dr. Kane, what was that she said? She said the foods that we're supposed to eat don't need a label. And so just that easy, right? So when you think about the foods that we should eat, which are tied into making sure that we manage our blood sugar, our blood pressure well. And of course, we're talking about fresh fruits and vegetables versus those other foods that unfortunately, when I look around, Dr. Price and Dr. Green, when I go to the grocery store, I'm looking at grocery carts, and OMG, is so much junk in folks' baskets, and starting out with their children. And that's the thing that I've liked about this show is we've really been trying to bring experts like yourself on to say, hey, you maybe it's too late for you to reverse your disease, but think about your children, right? And what can you do to make those different changes in your life? Dr. Price, what are you finding is the most difficult thing for your patients managing their going to dialysis or their kidney disease?
Their kidney disease, I guess, managing the underlying problems like diabetes and high blood pressure. A lot of them they feel good, so they think everything is fine and they don't need to take medication. Some of them don't even know what medication they're taking or what it's for or how often they should take it. And when you see people coming with a list of 10 to 12 different medicines, I don't think they're taking it. And you have to sit down with them and actually write, this is what this is, put it on a card, because if you're seeing different doctors, somebody's going to make a change so everybody knows. But I think that's the main problem, is them trying to keep track of their medication and what it's for.
Dr. Green, in the families that you deal with, and maybe a child, an adult child brings their parent or grandparent to the doctor to see you, are you finding that you can look at the family members and say you're next if you don't if you don't do anything? Obviously, you're not going to say that, but do you know what I mean? Like, are you finding that some of these issues are really passed on from one generation to the other, these bad habits?
Yes, yes, indeed. And you can tell. In the room, you'll have a hypertensive patient who is diabetic, and you mentioned the important word diet, who is also obese. Obesity, of course, we measure it in our world using what is called the body mass index, the BMI. And anything above 25 begins to cause us concern, to keep the numbers simple. And then anything above 30 is a cause of great concern. And it is very difficult, I find, in my practice. I'm sure Rogers will attest to that as well. Is that using the word obesity has its drawbacks, and once you use the word obesity, you got to be so careful after that, because you might lose half of the battle just by mentioning that one word. And so what I've been trying to do is to try to get at it in as softly as we possibly can. Uh, but certainly, when you're in the room and you look at the relatives, the granddaughter or the daughter, one of the things that we are struggling with in the African American community, pure and simply, is obesity, and that's a struggle. One of the beautiful things about being on this evening is that I just learned something very interesting. While I might be the expert here, I'm also a learner. You just mentioned something that was a thing of beauty, and I'm gonna beg to steal it from you. You said the dietitian mentioned to you, and I wrote it down so that I got it right. What you need to eat doesn't have a label. That is a thing of beauty.
Isn't that what that
That
was
is,
just so powerful, right?
that is smooth. That's
Yeah.
impressive. And the way I tell it to my patients is that they should stay away from processed foods.
Hmm.
But that says it even more succinctly. You don't have a label on an apple. You don't have a
Hmm.
label on a mango. You don't have a
Nope.
label on your vegetables, your green leafy vegetables. It's
Nope.
pretty impressive. So that if I when I leave here tonight, I will have learned something, which meant that this hour that I spent with you has been pretty valuable. Uh, the the kind of patients that Dr. King sends to me, almost certainly will fall in that group. The hypertensive, obese, diabetic patient who is coming to me because they need to go to surgery, or they need to have a procedure done, or they're having chest pressure, or the blood pressure is just difficult to control, or they have abnormal changes on the EKG, and he's trying to figure out, what do I do next with this patient. And before we even get off the conversation, as soon as you walk into the room, you almost certainly know what the challenges are before you even get the medicines. And so the dietitian becomes a very, very important ally
Mm-hmm.
in the conversation of managing hypertension.
Yeah.
I happen to love oxtails.
Me too.
And Kentucky Fried Chicken.
And
Oh, she
Kentucky
got
Fried
all
Chicken.
you secrets, Dr. Green.
You see why this is not a fair debate, right?
I'm just waiting on it.
That's fair. I teed it up so well and chicken, boom. Anyway, but that's what is out there. It's ubiquitous. KFC, Popeyes, churches, the list goes on and on.
Mm-hmm.
And the beautiful, the struggle is the cost.
Right.
You pick up 4 pieces of chicken for, I can't even say the price because then you know they do it often from from KFC,
Oh, it. You know.
and it is relatively inexpensive compared to stopping at and of course you can drive right
Right.
up. You don't have to get into your car, right?
Yeah.
It's so convenient as
Yes.
opposed to having to drive to the parking lot, find a parking space, walk into the
Supermarket.
whichever one it is, and you will never see a vegetable or fruit at the front.
Exactly.
You will never see it on checkout. You gotta go look for it. And then when you find it, it is relatively expensive. Come vis-a-vis, stopping at one of the fast food establishments. And that's a challenge. So there's an
Yeah.
economic burden to lift.
And
And
that's where pre-planning, Dr. Green, is important. You got to go to the grocery store on your day off. But when you go, the other lesson that we've learned from these conversations is stay on the outside of the store, because all the bad stuff is on the inner aisles of the store. The fruits and vegetables and everything that you should really have is on the outer part of the. But we tend to slide down. We see the signs, and you're right. You don't see apples and bananas at the checkout. You're seeing bananas more than anything, but that pretty much even at the gas station there are bananas, for example. If you're just tuning in, we're talking to Doctors Price and Green about heart disease and hypertension. If you have a question for the doctors, dial in now 888-669-1280. And of course, if you're shy, you can always write your questions. We're talking about hypertension and heart disease because it's so prevalent in so many communities. It's something that folks struggle with. And sometimes, doctors, I believe that people think because their parents had it, it's inevitable that they will have it and suffer from it. However, they have to know, which is why we've had our dietitians like Linda Brown on so often, is because we're inserting it all the time that there are things you can do about it. We haven't even talked about taking a walk. I've even shared with people I retired from the health department. I used to tell people when you're planning your family reunions right now, where people are talking about the summer, getting together with their family, include fitness activities. Don't just plan the meal, the who's going to make the macaroni and cheese and potato salad and the this and that and the other.
Oxtail.
The barbecue. Well, see, Dr. Green, he had to call you out again, right? Really? But I mean, really plan some family activities. I remember back in the day, doing tug of war, sack race, those competitive activities with families outside. Not I'm not talking about games inside. I'm talking about outdoor games and just even going for a walk. I remember years ago, Dr. Ken Jones was talking to a group, and he was telling them, if you when you finish eating, go out and go take a walk afterwards with your family, with your friend, right? Just take a walk, right? And of course, you didn't talk about managing stress, the importance of managing your stress in order to re, uh, manage your diseases. Dr. Kane, I've been rambling on. Do you have a question for the doctors?
I know. Well, yes and no. I'd like to ask either or both. And we have physicians that listen to the show, by the way. So we have to start examining, especially when it comes to these primary care docs, And some of the patients, if you're talking, and I'm going to talk with you, Dr. Price, you're talking chronic kidney disease. Okay. As you know, there's different levels or whatever. Let's talk to the patient. I'm going to have you talk to the patient and explain to them what chronic kidney disease is.
Okay. Well, first, we know one of the main things that the kidney does is to filter the blood of toxins. The liver also does it, but the kidney does it as well. So the kidney filters the blood. And we find when you're born, you have a certain amount of nephrons, which is the functioning unit of each kidney, and about 1 million in each. And, we say your filtration rate might be about 100, and it stays up there until you're about 40 or so. And then because of age, it does start to drop a bit. So by the time you're 80, that filtration, cleaning out the blood, was about 50, 55%. Okay. And that's what you might say age appropriate. It's not normal because it's not what it used to be, but that's what you would expect with an aged kidney. So now I see patients who might be 40 and 50, and that filtration rate, which should be probably 80, is like 30 and 40. So that's pretty, moderate, almost severe kidney disease. And that is in a typical patient. There should not be any blood in your urine. And it's sometimes hard to know where it's coming from. But when it's coming from the kidney because you've ruled out bladder problems or problems in the ureters, which are the little, it's the little line that you see that connects the kidney to the bladder. If it's coming from the kidney, it can be very aggressive as far as damaging the kidney because it's bothering the vessels, which the kidney is made up of a whole bunch of microscopic vessels. And also, you shouldn't see protein in your urine. Protein is in the blood, and it's a really big molecule. So, as I mentioned, the kidney filters the blood. So, things like water, electrolytes, sugars come out, but protein should not. So, if you start seeing protein in the urine, which is something that has to be measured by your doctor, then something's not right. And usually that's the first thing you see with kidney disease, seeing protein in the urine. So this is why a lot of diabetics should get their protein, or they call it albumin, checked regularly. And usually it's protein in the urine that we see with hypertensive kidney disease.
I try to make sure that patients understand one thing you mentioned was blood in the urine, one is microscopic. You don't have to actually see the
Right.
blood. There doesn't need to be discoloration. It can be microscopic. So that's one thing you have to pay attention to. The other part I want to make sure patients also understand is that when someone says, "Oh, I go see a kidney doctor," the difference between a urologist and a nephrologist.
Yeah.
One is addressing the housing of the kidneys.
Right.
I call it the mechanical framework of the kidneys, and the other one is actually addressing the filtering.
Right.
And because of that filtering, definitely, as you mentioned, is done by blood vessels and how stable they are in terms of their lining and so on and so on. We have to make sure that we distinguish between problems with the housing of the kidneys and problems with the filtering of the kidneys.
Right.
The filtering sometimes is affected by what happens with the blood vessels themselves in terms of atherosclerosis, yada, 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 which now I bring over to Dr. Green to come into focus to talk about vascular disease and the role that it plays with both heart and almost any of it, but the role that it plays with heart and renal issues.
Yeah, the vascular disease is very important. We are getting more and more sophisticated at that level. The things only work if blood goes there. So the kidney has a blood supply of its own. The heart has a blood supply of its own. And the healthier you keep that blood vessel supplying your organs, the healthier you will be. Hypertension, diabetes will affect the lining of the blood vessel. So one has to try to make every effort to protect that lining of the blood vessel so that blood can continue to flow adequately to all the organs, especially kidneys and heart. Um, it is a very complex issue. The lining of the blood vessel is actually a living organ. And actually, when I began medical school many moons ago, the liver was supposed to be the largest organ,
Right.
and then over time, with our knowledge, we found out that the skin was the largest organ. And now, lo and behold, the largest organ out there basically is something called the endothelium, which is the lining of the blood vessel. And that lining of the blood vessel is very susceptible to high blood pressure, to diabetes, causing wreaking havoc with that blood vessel. And I get to see the end point of all the damage when we have a heart attack. But it begins a long time before we get to an actual heart attack. How do you protect the lining of that blood vessel? Is we're still learning. But what is very important is that we have to make sure that the things that we can do at our level, controlling the blood pressure, controlling the sugar, controlling the diabetes, those are fundamental. Controlling obesity, and weight gain. Those are some of the fundamental things that everyday people can do to try to protect the thing that you really can't see, which is the blood vessel in the heart. So
And why?
it all comes back to dieting. The more you can keep your body as alkaline as possible, as opposed to acid, which is what the body will tend to, regardless of what you do, then the better it is, to keep that lining of the blood vessel down. Vascular work in the country is becoming very, very common. There's specialty in itself. Just looking at the blood vessels, uh, but hydration, drinking a lot of water, hydration, keeping that blood vessel full and occupied, keeping things flowing, not getting dehydrated, especially in the warm summer months. Um, Trying to use, well, the quality of the water is also very important. But all things being equal, you want your water to be as alkaline as possible, and just as importantly, containing some electrolytes as well. Because when you literally pee you don't lose plain water, you lose some electrolytes, as Dr. Price had mentioned, which is a natural phenomenon. You can't overcome that. So you electrolyte water is something that I've been trying to impress upon my patients to do. But you really should drink water. My patients always ask me, well, how much water should I drink? Well, it varies from person to person. But for example, I say to golfers, if you play the first 9 holes and you turn and you haven't peed, you're in trouble. I say to my patients, if you go through the entire morning and you haven't gone to the bathroom at least once or twice, you're dehydrated. So peeing is not a bad thing. It is actually a very good thing. I know
Right.
it's a misery, it's an inconvenience, but it shows that your volume is up. And that helps to protect the blood vessels. It helps to protect the kidneys. It helps to make sure that the heart is working properly. So these are simple, upfront things without getting too sophisticated as to how patients can try to help. Hydration is very, very important.
Dr. Price, can what can you appreciate with the color of the person's urine?
Usually, when it's a pale yellow, that looks good. People tell me they have their urine looking like dark, like tea colored, and it shouldn't be dark like that. And that means you're pretty dehydrated. And sometimes it's hard to tell when you take a water pill or what they call a diuretic
Hmm.
because it doesn't allow you to concentrate or dilute your urine very well. So it's always hard. But if you see dark urine and you're taking a water pill, you are severely dehydrated.
Wow.
Dr. Green mentioned the vascular injury that occurs uh, with heart disease. Can you elaborate on is that the same thing that occurs with kidney disease? vascular injury.
Well, it can occur. I mean, high blood pressure, that pounding on the vasculature does bother the kidney. And, a lot of people who have uncontrolled high blood pressure, and
And
now we say that control level for the kidney is less than 130/80, that over a 10-year period, they're going to then be on dialysis. If it's worse than that, there might be on dialysis much before that.
One of the things that just came to mind, Dr. King, as we speak, Dr. Price, is most people will wind up getting an ophthalmology appointment at some point in time in their lives. And one of the interesting things that the ophthalmologist does is to look into the back of the eye, almost certainly. But let me pause for a second and make a distinction between an optometrist, a guy who will cut glasses for you, and an ophthalmologist who is a doctor and who's going to literally examine the back of your eyes. And by the time you get to be in the age group that we are in, and I'm not going to mention which age group that is, you have to worry about pressure in the eyes, and you have to and just for men, and you have to worry about your blood vessels. So when you go to the ophthalmologist, the doctor, for whatever reason, you're gonna have a little bit of an advantage. Actually, insight is probably the better word, about what is going on with the blood vessels in your eyes. And those blood vessels actually are very interesting size because they will, whatever is happening to your eyes are gonna be happening to your heart, and it will be happening to your kidneys, because the smaller blood vessels that permeate the muscle in the heart and permeate the nephrons that Dr. Price talked about, those little tubes and blood vessels in the heart, they start to approximate to be the same size. So if the ophthalmologist tells you that there's narrowing in the vessels of your eyes, so which they will do, if they almost certainly they will look at them, that's a marker that you're getting into trouble. And I mention this because you might not have high blood pressure, you might not even know you have high blood pressure, you might not know that you have diabetes yet, but it's altogether possible that might be another visit, another encounter with a physician that could be used as a good tool.
I let patients know. I'm gonna say this real quick, and Dr. Price, I want to go let you. What you're saying, Dr. Green, is exactly correct. The eye is the only place you can look at directly at a blood vessel without it being obscured by skin and other viscera and stuff of that nature. You can actually see the blood vessel, and so it can give you a huge amount of information if you pay attention to it, and you get your eyes examined.
And you get your eyes examined.
Right. And I was going to say that for a diabetic, when they say, oh, I can see diabetes affecting your eyes, it has already affected your kidneys.
That's right.
It's already affected your kidneys.
Yeah, the cat is already out of the bag.
Wow. Yeah, I wanted to ask you what's really considered a normal blood pressure, and does it vary by age?
Well, for the kidney, our goal is less than 130/80. And it didn't used to be that way. It's changed over the years a lot. I mean, before it was like 160/100. And then it was 140/90 for a long time. Mm. And I think what they found is that when they did autopsies or they did biopsies of kidneys and they realized people were having blood pressures of 140, 150, they would see changes of high blood pressure in the kidneys. So this is why it was lowered down to 130/80. Now, sometimes it can be too low such that you're not getting blood to your brain and you're getting dizzy, especially when you stand up. And we do see that in older people. So we tend not to be as so strict trying to get it to that level of less than 130/80. And as you get older, your systolic, which is that top number, does tend to go up. And the bottom number, which they call the diastolic, tends to go down. And high blood pressure medicine will make both of them go down. So it's always sort of a line that you walk to try to have the diastolic not so low, but the systolic not so high. Because it goes up, yeah.
I like to just give credit where credit is due. A lot of that thinking that occurs now, and some of those changes It may not say it from a national standpoint, but we can attribute it to the issue, the International uh, Society of Hypertension in Black folks.
Yeah.
Okay, mostly about Black doctors attributed help help frame the framework or help make the framework by which we make these blood pressure changes and adjustments. Black doctors like the two we have on our website this evening.
Yeah,
So we,
a lot of that work came out of a very interesting study called the AHEF trial,
Yep.
The heart failure trial.
Mm-hmm.
Very important trial, and that was done mainly in African Americans.
so we talked at the beginning about sodium and hypertension. What's a normal amount of sodium that one should have a day? And does it matter? Does it vary with African Americans versus the general population?
I usually tell patients a gram of sodium a day because I know that they're going to go to 2. So, and it's hard. Everything you eat, even fruit has some salt in it,
Mhm.
but, I don't, and people look at the salt that they add, but it's usually the salt that's already in the food. So I
Mm.
tell people I don't mind fresh pork, but I don't like ham, because it's processed and it's very salty. And the older we get, the more salt sensitive we also are. And as a group, African Americans tend to be salt sensitive, meaning that you hold on to salt longer. Normally, when you eat salt, you should pee it out within the day. But as we get older, you hold on to it a little bit longer, and your blood pressure goes up. You see a little bit of swelling there, So as we get older, we do become more salt sensitive.
By the
Doctor,
way, Dr. Price, hold on, Dr. Kane, I just have to say this. Dr. Price and Dr. Green, we've used the word pee and more on this podcast than any previous podcast we've done.
but that's why this podcast works. Because we get down to the nitty gritty. It's culturally sensitive
Yeah.
approach to things. Dr. Green, one quick question, one statement, and then your comment on it. I tell a lot of my patients, mostly the men patients, but I will tell the women because they can help get the men in to be taken care of. Erectile dysfunction may actually be the canary in the gold mine as it relates to renal and cardiac disease or vascular disease. Any commentary on that?
Oh, absolutely. It is no question at all about it. Again, the size of the blood vessel is also very important, and most men, and of course, the erectile dysfunction is a very sensitive issue, especially in the Black community, but right across the board. And how you address it in the office when you visit with patients varies from person to person. You actually have to smell it out and have a good sense to know where to go. Uh, but erectile dysfunction is directly related to hypertension and diabetes. And the common pathway basically is at the level of the blood vessel. To get an erection, you need a good blood supply. To get a good blood supply, you need a good flow of blood into the penis, and that's the only that is huge. And remember that the size of the vessels, of course, are similar to the vessels in the secondary size around the heart, as well as the sizes around in the eyes and at the level of the kidneys. So the one of the earliest signs, and we know this now for a fact, of problems is indeed erectile dysfunction. The ability, and that blends with libido. Not only the ability to feel the need for an erection. Number one, libido, excitement. Two would be the actual ability to increase the size of the penis, erection. And then the next part of it is the ability to have an ejaculation, and then of course an ejaculation itself. So there are four little stages that push on from time from the beginning out to the end of the whole process. Used to be a taboo conversation in the early days. Now I find that patients have absolutely no difficulty at all questioning me about ED. What is also very impressive and I think very important is that the men don't usually start the conversation. The wives start the conversation, and so it takes a little bit of skill to and a little bit of sensitivity and to be able to address it. I put in pacemakers in all sorts of different ages of patients. And what floored me one day really was the 88-year-old lady who asked me when can she get back to hanky pankying. And it caught me by surprise because it was the last thing on my mind, tell you the truth. But but so human sexuality is very important, and it is a good segue to getting patients to believe in you and then follow the things that you do if they feel that they can invest in you and divest in you and give you confidence in making those kind of decisions. When you harness that kind of fidelity with your patients, you can get them to do a lot of different stuff vis-a-vis the hypertension, vis-a-vis the diabetes. You remove that taboo, they can open up to you more. So that is how I play that game really with my patients.
Speaking
How
of
about
segue,
sleep apnea
well,
and
man, hold up, Mr. Turner. I can't get off the subject here because I got to make sure this is an important thing. Um, Speaking of segue, um, first of all, Dr. Green talked about the size of the artery, not the size of the organ. First of all, but on top of that, what I wanted to make sure is that people also got, or the men that are listening especially, but the women who help take care of them, the role that if you have cardiovascular disease and being treated for it, that you have to be careful of those erectile dysfunction aids, the Viagra's of the world. And so speak to that real briefly. And because that you have a lot of men that go out and want to take these drugs, but they may also be on other drugs that can cause a worsening of their health, heart attack, whatever.
Yeah, that's a very important point, and I'm glad you raised it. Um, the the I am not a fan of Viagra. It will take me about 5 or 10 minutes to explain why. But the suffice it to say that the when I give patients, particularly men, or especially men, erectile dysfunction medicine, I defer to tadalafil or Cialis. Cialis is the trade name. Tadalafil is the generic name. The difference, of course, is cost. So when I write a prescription, I almost always write Tadalafil as opposed to Cialis to get the cost factor out of the way. Number one. Number two, it is one of the advantages of using Cialis is that it also helps with males who have a large prostates as well. So it helps the flow of the of urine. And so if you're getting it 2 or 3 times at night in the early stages, Cialis go a long way in pushing off or delaying the side effects of BPH, which is benign prostatic hypertrophy, i.e., enlargement of the prostate as you get older, which will naturally happen in men. Uh, the Cialis also has a beneficial effect on the at the level of the artery. Remember, we talked about the endothelium, the lining of the blood vessel. Tadalafil, and again, Cialis, tadalafil, also helps at that level as well to dilate the blood vessel. And so, if you have concomitant heart disease, so-called coronary artery disease, blockages in the vessel, and you have erectile dysfunction and you want to treat it, the safest drug to use, and I say this categorically, would be tadalafil as opposed to Viagra.
You know,
Sildenafil. And I also caution there are if you go into the liquor store or you go into gas station, there are a lot of over-the-counter
Hey,
pills that you
mm,
can use, and these are they're not regulated properly to begin with. They probably should only be used by younger men who don't need them anyway. And but when you get to the level of ED, it surely should be managed appropriately by your physician. And you should not be bashful about talking to your physician about erectile dysfunction. Very important for multiple reasons. The main danger is blood pressure. If you use sildenafil or Viagra on a on an off basis, the chances of dropping your blood pressure and getting into trouble is high.
dropping it too low, you mean?
Dropping it too low, correct.
You know, one of the things, and Ms. Turner, I promise I'm gonna let you back in. But one of the things that I early on in those development of those drugs categorically used to be the concern of the prolonged activity of the Cialis, and if a person winds up doing nitroglycerins or some of the nitrates, and the risk that they have for for having a heart attack or a complete heart, uh, I'm gonna say failure because of whatever it does, the inability for you to pump, or the dropping of the blood pressure as it was related to the nitrates.
Right.
But I'm hearing you say that Seattle was better. I think one of the concerns early on was because of its longevity. We're trying to keep this blood pressure up in people who taking the nitrates, even though they shouldn't.
Mm-hmm.
There's still people out there that don't warn them about it,
Right.
and the safety of doing that. Has that thought process has changed? I'm taking it.
It's changing. It's changing. So I have a very good experience in my own practice with Cialis. I've not had any issues with it at all. I've had issues with sildenafil, which is Viagra, again because it's a one-time effect. It's a spike. Whereas on a continuous basis, the tadalafil Cialis levels out, and like the human body gets accustomed to constancy, if you will, as opposed to just taking a Viagra here and a Viagra there is really not safe, especially if you have coronary artery disease. So when your physician warns you about taking a Viagra, that is expressly what he is concerned about.
Ms. Turner?
So I wanted to ask a question about sleep apnea and hypertension, or is it related to heart disease at all? Can it increase, having sleep apnea, obstructive sleep apnea, affect your heart or your blood pressure?
Especially as it relates to like AFib or something along that line.
Yeah. Dr. Price, you want to answer that, or you want me to jump in?
Well, I mean, your blood pressure can go up with sleep apnea, and it can be worse when you have sleep apnea. So that's why they usually screen people, for sleep apnea when they do have difficult to control blood pressure. The AFib part, I'll let you handle, Dr. Green.
Well, the reason I deferred to Dr. Price is because we have a personal relationship with sleep apnea.
You mean the oxtails?
Yes, for those audience folks out there, have sleep apnea. If you look at my neck, I have a long neck. I am not obese. I don't have a short, stocky depth, but yet I have sleep apnea. The point that I'm making is that sleep apnea is very, very common. Number one. Number two, it is an easy diagnosis to make. And number three, most men, particularly men like myself, avoid making the diagnosis. It took my wife about 3 years to convince me that I had sleep apnea. You see? And it was only when the pet cat that we have refused to come into the bed to sleep with us anymore that I finally conceded And of course, I was taped, and I was asked to listen to this tape, and to make a diagnosis. And I listened to the tape, and I said, "Darn, that guy has some serious sleep apnea." And then, of course, I walked down that dark alley and got mugged. I was told was that guy is you. Why am I telling that story? I'm telling that story because most when you ask patients whether they have sleep apnea or not, they'll tell you, no, I don't have sleep apnea.
Mhm.
But that's the wrong
Mhm.
person to ask. You don't ask the patient. You ask the
The
spouse.
spouse. Yep.
Whether the spouse is a male or female, it doesn't matter. You ask the spouse because
Mhm.
you will never hear yourself snoring. Some people do, but you will never know the extent to which you snore. But the important thing is really not the snoring. The important thing is the lack of breathing, the
Mhm.
pauses that come after you snore, and you have that long pause. That's where the danger is. Sleep apnea, Ms. Turner, is very, very common. We have had a new awakening with respect to sleep. Sleep is so, so important.
Mhm.
We take sleep for granted. Uh, I hear a pretty interesting ad about don't worry about sleeping. When you're dead, you have an eternity to sleep. Not good. Sleep is huge. You must get at least a minimum of 4.5 to 5 hours of sleep every night if you're going to function physiologically properly. If you have sleep apnea, you are exposed to hypertension, migraines, arrhythmias, meaning abnormal heart rhythms. So it is very, if I see a patient in my practice as we speak who has an abnormal heart rhythm, and abnormal heart rhythm is the other kind of specialty that I do, they're almost certainly going to get asked a question about snoring, and that question is going to go to their spouse. And I always insist that the spouse come to the office with my patient. And if the spouse is not in the office, I get them on the phone. That's how passionate I am about it. Because if you can ward off a lot of hypertension, uh, it's very safe to say that because of the stresses of lack of good sleep, that you're a higher risk for diabetes. I can't give you a percentage, but I can give you an association, and your overall quality of life is going to be impacted by your inability not to sleep well. It also caught my attention personally when I was at the stop sign at around 1 o'clock, coming back from one hospital to the next, and the guy behind me honked at me. Pum, pum, pum. Why is this guy honking? Wait, hold a second. I just nodded off. Wow. Wow. So you got to pay attention. The other way that you will see it, for those that are listening again carefully, you're used to driving, 4 or 5 hours. Are you going to Savannah, 2 hour drive? Are you going to Orlando, 2 hour drive? And you think nothing of it when you're a younger man. Yeah, I can do 4 or 6 hours. And then you find that you halfway, 45 minutes into the drive, you start to hurt. You see? And it is not that you've fallen off to sleep. It is that you're shifting lanes a little bit, you're drifting a little bit.
Stretching.
As you get older, the wife starts to scream at you. Another way to get that triad started, but it's real. And then you find that you have to stop more often. You can feel it. You see, bad dreams. If you're having very bad dreams, or you're waking up at night with a headache, or you wake up in the morning with a headache, or you find you can't get around the corner. And by getting around the corner, I mean by the time it gets to be 1 or 2 o'clock, you start really dragging. Or after lunch, when you have a nice, good lunch, and that niggeritis hits you, that we call niggeritis, but technically it gets worse. That that is some serious sleep apnea. It is treatable, that first and foremost, and it can decrease the amount of medication that you might have to use to treat the underlying problem of hypertension, diabetes. The way to see it is that it puts your body in a much better space to be able to treat. Your karma is better, your sleep is better, your relaxation is better. Mhm.
Well,
This is doctor will see that.
unlike my wife, you did admit to. I mean, you accepted when you heard the loud snoring. At my house, it was, that's not me. And I'm going, okay, well, I'm the one recorded it, and there's no other person in the room. The dog can't do it. So it's gotta be you.
It
But
gotta
you
be.
still didn't accept it.
Mhm.
Well, we are at the end of the hour. It's been a wonderful show. I have learned a lot from you all. Dr. Green, I'm glad I shared something that you can use. And Linda Brown, if she's listening, she takes credit for that about the reading of labels. You've shared a lot. You've actually touched on some points I think that we probably should consider for future shows. Tyrone, our behind the scenes guy, even posted it, said, maybe we need to talk about dedicate a show to just the importance of a good sleep, right? And you also talked about erectile dysfunction. Dr. Kane, I can't believe that's something we have not had a show on ED. We had a men's health summit in the past, and we were coming up with titles of topics. And Dr. Kane said, just put ED and high blood pressure, ED and heart disease, ED and, you know what I mean? Just put erectile dysfunction, and you'll get guys coming in every room. And it worked, actually. But thank you all so much for joining us tonight. Learned a lot, appreciate your expertise as well as your passion. I can tell you both have a passion for what you do. At the end of the show, we always like to give our guests an opportunity to share your final thoughts for regarding tonight's topic. Just even if it's some nuggets that you want to impart on people. Dr. Price, I'll start with you. What are your final thoughts for tonight's show?
Okay, I like to end on a hopeful note here. So, when you mentioned that you could never get rid of blood pressure medication, I have seen patients come off their medicines. They lose 100 pounds or whatever. Yes, they can come off their blood pressure medicine and their diabetes medicine. So, there is hope out there. There's hope.
Thank you. I appreciate that. Thank you. Dr. Green, what are your final thoughts?
You are what you eat. Take care of your diet.
That's it. Just
That's
plain
it.
and simple. That's
Plain and
it.
simple. You are
Yep.
what you eat.
Thank you. Thank you. Dr. Kane, what are your final thoughts regarding tonight's topic?
I'm gonna piggyback on both. I agree with Dr. Price for sure. I have patients that I've taken out high blood pressure medications. Sometimes they get 10 to 20% weight loss and they can come off. Okay. And then the other part winds up being that you are what you eat because of past shows that we've done and the paucity or the difficulty in terms of trying to get healthy food from the supermarket that you can afford. Let's start our gardening. We've done at-home gardening shows. And so let's go ahead and start our at-home. My granddaughter just started hers. Regretfully, I got a bad back from helping her to build her her greenhouse. However, it was well worth the effort. And so it's something that we can start and grow our own vegetables and at least on a smaller scale to start. But for those who have enough room to do it on larger scales, and we still encourage churches and other institutions to also grow their own food as much as we can.
Thank you, Dr. Kane, Dr. Price, Dr. Green. Wonderful conversation. Hopefully, one day we will not see heart disease as a leading cause of death. I hope that we're able rather to share some information with you to make some decisions. No one ever said it will be easy. However, hopefully from tonight's discussion, you know that it is doable. Take the tips that the doctors recommended. Take the tips that our registered dietitian mentioned in the past, the personal trainers that we've had in the past. Next week, we're going to have someone to come on and talk about mental health. Dr. Richmond Wynn is going to join us because that is also something else that people struggle with when it comes to doing their daily activities. As always, thank you for tuning in to Pause for the Truth. I was going to say if you didn't vote, go ahead and vote, but the polls are already closed in Northeast Florida. So now we just wait and realize if our blood pressures are going to go up or stay managed as a result of who won the election. But again, thank you all for joining us and stay well and safe and continue to do the wonderful work that you're doing. Take care.
Thank
Good
you.
night.
Good night.
Thank you.
Good night.